Hey podcast listeners out there, Jim Sigler here for BrainWaves. If you've been following us for a while, you'll realize and hopefully appreciate that there has been incredible progress in neurodiagnostics and treatment of neurologic disease, and such progress in only the 4 years that we've been doing this podcast. During this time, we've also been making our own improvements to the podcast as well. This week on the program, we're pulling out a show from our archive on chronic and recurrent meningitis, with the audio remastered, an update on some of the latest developments in the evaluation of these patients. So let's get to it. Like all other diseases of the human body, meningitis exists along a spectrum. The patient with acute meningitis may have a recent fever, headache, or neck pain. There could be cranial neuropathies, double vision, or facial weakness. Sometimes your patient will look really sick, and they may be vomiting from intracranial hypertension. In other patients, the symptoms may be more subtle: malaise, chills. And when you get the lumbar puncture, or even the MRI of the brain, that's when you know it's meningitis. But what happens when your patient with meningitis comes back with a headache again, or with new fevers, or new neck stiffness? What should cross your mind when you repeat that lumbar puncture, and there's still some evidence of inflammation in the CSF? Recurrent meningitis can be difficult to recognize or to diagnose, and in many cases the cause remains unknown. But having the right mental framework can help you get started. To bring you more on this topic, Dr. Jon Rosenberg joins me for this week's episode of BrainWaves to describe how he works through a case of recurrent meningitis.
My name is Jon Rosenberg. I am a resident physician in neurology, and I studied medicine, and before that I studied history and Spanish. Within neurology, I have an interest in critical care and stroke and infectious disease as well.
Welcome to the show, Jon.
Pleasure, Jim. I'm a fan of the show, so it's good to be on.
So let's start with a bird's eye view. How do you conceptualize meningitis, and where does recurrent meningitis fit in?
I think you can divide meningitis into two main categories: aseptic meningitis or bacterial purulent meningitis. There's also recurrent meningitis, chronic meningitis, and subacute meningitis. With the difference being that subacute meningitis lasts less than 1 month, and chronic meningitis lasts at least 1 month with persistently abnormal CSF findings. The main thing for recurrent meningitis is that there is a period of both clinical recovery but also normalization of the cerebrospinal fluid.
So when is it headache, and when do you start to suspect something more concerning like recurrent meningitis?
That's a good question. Generally, you have to think, do they have fever? Do they have meningismus? And I think the look of the patient is really telling. Like, do they look like they have meningitis? When do you start to suspect recurrent meningitis? It's really going to be in the history, and the devil is really in the details. Has this happened before? Have they had a lumbar puncture? What were the cultures? A good history is going to tell you whether or not this is recurrent meningitis.
John's absolutely right here. The devil is in the details, and getting a good history is imperative. William Osler, the father of modern medicine, is once credited for having said, "Listen to your patient. He is telling you the diagnosis." Now that's not always the case, but when it comes to headache management, where the exam may not always be so helpful, the patient's story will reveal the diagnosis. Obviously, it's going to be a little more challenging when this is your patient's first ever headache, because now technically this is their worst headache of life, which carries its own differential diagnosis. And we covered this before with Dr. Kankanian in episode number 8. Even so, the most likely cause of a new headache is going to be something benign. Does your patient have a new severe debilitating headache with photophobia and phonophobia, nausea and vomiting that's lasted several hours to a few days? And does this headache improve with sleep? If so, then you may be thinking migraine. And although you can have neck stiffness with migraine, this should make you more suspicious of meningitis, as should the symptoms of nausea, vomiting, and photophobia. And definitely a headache with any new focal deficit, like a new cranial neuropathy.
They can, but often they won't have a focal deficit. Often it will be a general malaise, drowsiness, decreased energy, fatigue. I think it's kind of a case-by-case basis, but when in doubt, you can always do a lumbar puncture. I think for recurrent meningitis specifically, you're going to want to look for the history, has this happened before, and exposures, like what were they exposed to, any new medications, also past medical history, what diseases they have. All those will kind of help you tell, is this something new that's recurring again and again versus is this something that's kind of run-of-the-mill.
At this point in our 2017 interview, we finally dove into the meat of our discussion. What does it mean to have recurrent meningitis? How do you define it? Some discussion points that are probably more relevant for research, to be honest. And more importantly, what are the causes that you should think of when you encounter a patient with meningitis? I had asked Dr. Rosenberg to join me on the show back in 2017 because he was the first author on a really good review article about recurrent meningitis. And if you search PubMed for recurrent meningitis, his paper is going to come up at the top of the list for best matches. Anyway, here's how Dr. Rosenberg and his colleague, Dr. Benjamin Galen of Montefiore Medical Center, defined recurrent meningitis. For recurrent meningitis,
we define recurrent meningitis in its broadest sense as at least 2 episodes of headache, fever, and meningismus with associated CSF pleocytosis separated by a period of full recovery. The headache in recurrent meningitis can be mild or severe depending on the underlying etiology. In addition, some causes of recurrent meningitis can be accompanied by focal neurological deficits, particularly in the case of neoplastic meningitis, sarcoidosis, and Sjogren's syndrome. Recurrent meningitis typically presents as aseptic meningitis, while recurrent bacterial meningitis is usually the result of a predisposing anatomic defect or immunocompromised state.
One thing that I learned when I read your paper on recurrent meningitis is that there's a wide range of causes for recurrent meningitis, and some probably overlap with what you described as subacute meningitis and chronic meningitis. Can you walk us through how you delineate these etiologies of recurrent meningitis?
Sure. There are 5 causes of recurrent meningitis, and these are also causes of acute meningitis: infections, malignant neoplasias, benign tumors, medications, and autoimmune diseases.
Which one's the most common, do you think?
For recurrent meningitis, probably infections, HSV2.
And that would be what we classify as Mollaret's meningitis?
Mm-hmm.
Do you think that that may be the result of, sampling bias? I would imagine that people take ibuprofen or NSAIDs, which are one of the major causes of recurrent meningitis, all too frequently and then develop rebound headache, and we end up calling it medication overuse headache, when in fact it may actually be a recurrent meningitis if you were to actually do lumbar punctures on these people. But we don't do lumbar punctures on all these people. Do you think that we're missing a lot of cases of recurrent meningitis? And what does that really mean when we're seeing these people in clinic?
That's a great point, Jim. I think there is a sampling bias, and it's always very difficult. You have to be careful in how you say and how you quote statistics, incidence, prevalence, how you compare different causes of meningitis, because it's going to be based on the people that we tap and the people that we want to tap, and that's going to determine our data. So maybe when you're out there seeing a patient on your own and you suspect recurrent meningitis, maybe your mental heuristic is to organize a differential based on you think what's most common and to go from there. Or maybe you'd rather approach the differential more comprehensively. While obtaining the history, you're wondering if the patient has any personal or family history of autoimmune conditions. Behçet's, lupus, sarcoid.
Known viral exposures.
HSV2, VZV, HSV1, Epstein-Barr virus, HHV4.
Or history of cancer.
Small cell lung cancer, melanoma, breast cancer.
Or something that might make you think cancer. What meds were they taking?
The non-steroidal anti-inflammatories, antibiotics, so Bactrim, for example, is classic. Anti-epileptic medications such as lamotrigine, immunomodulatory agents such as methotrexate, IVIG, TNF-alpha inhibitors. Something we can get into later as well is, with a lot of these new targeted therapies for cancer, so antibodies for, cetuximab, intrathecal trastuzumab. These are new therapies we're using for cancer, and those can also cause recurrent meningitis.
Do they have any unusual physical exam findings? Any palpable lymphadenopathy? Evidence of melanoma? Abdominal masses?
They have oral ulcers, if they have vesicles in their ear,
which we can see in the Ramsay-Hunt syndrome. Or maybe it's related to a benign tumor in the brain. Usually this would be something like a craniopharyngioma or an epidermoid tumor, which can sometimes spill their contents, causing an aseptic meningitis. But you would say most of these people who come in with recurrent meningitis, they come in because of some sort of exposure rather than a predisposition to developing this condition?
Yes, they likely do. And part of that's because we just don't know the predisposition. But I think narrowing down the exposures are key. Is it medication, autoimmune disease, viral infection, anatomic deficit? I think you can also talk about trauma as well. Do they have any surgeries, any skull-based injuries, inner ear malformations? All these should clue you into predisposing conditions.
Also, among the causes that you mentioned, you said infection is a major cause. And besides viruses, which can, I guess, remain latent in the dorsal root ganglia for the herpes family, bacterial causes, you said, can also cause recurrent meningitis. How is this possible?
So the two main reasons why someone would have recurrent bacterial meningitis are anatomic defects and then disorders of their immune system. So with anatomic defects in children, this could be congenital. They could have, midline defects such as like meningomyelocele, congenital dermal sinus. They could also have inner ear defects such as Mondini dysplasia. All these will predispose the child to having recurrent meningitis. In adults, the most common or caused by far and away is trauma. So surgeries, skull-based injuries, motor vehicle accidents, all of that can cause CSF leaks and recurrent bacterial meningitis. The other cause is immune disorders. So people with both congenital disorders like A-gamma globulinemia, common variable deficiency, that can predispose them, and also people with sickle cell can have functional asplenia, or trauma, splenic rupture. So those are going to be the two things you have to search for.
So anatomic defects and immunodeficiencies for recurrent bacterial meningitis. And then among the viral causes, you said that HSV2 is the most prevalent. But many people I've worked with tend to stop there, and then they get caught up calling it recurrent aseptic meningitis, something like Mollaret's meningitis, which we attribute to HSV2. Why do you think this is?
So that's a good question, and I think to answer the question,
I love that all my questions are such good questions.
We don't know. But to step back, let's step back for a second and say recurrent aseptic meningitis or recurrent benign lymphocytic meningitis was first identified by Pierre Mollaret in 1944 in his case report of 3 patients. And he found that patients, they had recurrent fevers, chills, lymphocytosis, and these large cells in the first 24 hours called Mollaret cells, which we believe now to be of the monocyte lineage. For a while, they didn't know what caused Mollaret meningitis, but with the advent of PCR in the 1990s, they began to discover an association with HSV2. So recurrent meningitis is very rare. Only the biggest study, there's a study from Finland that showed the incidence was 2.7 out of 100,000 people had recurrent meningitis over a 10-year period. The vast majority of these patients, though, had HSV2. So I think in general, you're not wrong. It is very rare, but once you start to see recurrent episodes, herpes simplex should be high on your list.
Is it ever Lyme disease?
It's highly controversial, but we don't really know. Has Lyme disease caused recurrent meningitis in the past? Yes, but it's not it's not something that really the literature has captured as being an epidemic or a phenomenon.
How often do neurologists identify the cause of somebody who comes in with recurrent meningitis? You get the lumbar puncture and it shows a lymphocytic pleocytosis. They do have nuchal rigidity and they have no underlying cancer, no family history of autoimmune disease, no personal history of autoimmune disease. When are we missing things?
So often we don't find the cause.
When Dr. Rosenberg says that we don't often find the cause, he means about a third of the time.
Also, again, the definition of recurrent meningitis is that there has to be a period of symptom freedom and resolution of the CSF abnormalities.
With recurrent meningitis, as far as I understand, your exam often cannot help you in distinguishing the causes of meningitis, and imaging doesn't help much either. Besides the specific PCR, or antigen testing, or culture, or an autoimmune serology, is there anything about the CSF that can push you to think one cause more than another? For example, when we think of hypoglycemia, that might raise my suspicion for bacterial or fungal infections, tuberculosis, or carcinomatous meningitis. And if I see a high-grade pleocytosis, then I'm more concerned that a bacterial infection is more likely.
I would not use, in patients who have autoimmune conditions such as Behçet's disease, lupus, sarcoid, they can have a very high lymphocyte count in their CSF. I know I've thought, and I've even heard some of my colleagues say, like, oh, well, that lymphocyte count is like several hundred. That it can't be like, this autoimmune condition. And in reading the literature, like often patients could have a lymphocyte count of 500 with Behçet's disease, lupus. So I wouldn't use the absolute number of the lymphocyte count to help steer you, is this an infection versus this is an autoimmune disease.
All right, so we've covered a lot regarding the etiologies of recurrent meningitis and the diagnostic testing. Let's move on to treatment. I don't think any of our listeners are going to be surprised if you said that treatment is going to be directed at the underlying cause. But there's more to treating recurrent bacterial meningitis than throwing more and more antibiotics at these patients. What can you tell us about that?
Well, I guess the treatment for recurrent pyogenic recurrent bacterial meningitis. So the treatment is going to be correcting the underlying cause. So if someone has a structural deficit, you're going to correct it, and you're generally going to first have to search for it, and the history will probably provide you a cue. Do they have trauma, congenital deficits, probably have an MRI brain with and without contrast. Also, if they have, if you're concerned for an inner ear problem or a skull base problem, you can do a CT of the temporal bone, CT of skull base. So you want to fix the underlying anatomic deficit. And then for people with a congenital immune disorder, an immunodeficiency syndrome, you're going to want to obviously consult, an immunologist, but they should be up to date on their vaccines, and they should also get the pneumo vaccine as they get older. But the best treatment is to be up to date on their vaccines. Of note, practitioners will often put patients on antibiotics who have an immunodeficiency syndrome or who have a structural problem leading to recurrent meningitis. The evidence hasn't really shown that this works. So
maybe in a patient who's not amenable to surgery or not a good surgical candidate, or for whatever reason, we can't fix their underlying immunological disorder, maybe prophylactic antibiotics is...
Especially for people with an immune disorder, there's not good evidence behind it. And then for people who have a structural deficit, recurrent CSF leaks, evidence has shown that antibiotic suppression doesn't work. It doesn't prevent recurrent meningitis.
What about the treatment for your typical case of molaraise? Is there any evidence that antivirals are effective for these patients?
There was a trial of using valaciclovir. This trial did not show any benefit, but there were several flaws. So basically, the trial took patients with recurrent meningitis and randomized them to receiving valaciclovir and not receiving valaciclovir for 1 year, then followed them for 2 years. The problem with this trial is, 50% of the patients just had one episode of meningitis, HSV2 confirmed meningitis. So they didn't have true recurrent meningitis at the start of the study. Also, patients in the experimental arm that actually received valaciclovir, they had more episodes of meningitis than the control arm. It was not statistically significant, but they had more episodes. When valaciclovir was stopped, you see the incidence of meningitis increase in this group. So it makes you wonder, was there an implicit difference between the two groups that was not accounted for when they were randomized? And just anecdotally, I know we do have physicians at our institution who use valaciclovir for these patients, and they have found it successful.
What about for the patients who don't have HSV2? They don't have cancer, they don't have an autoimmune disease. How do you treat them?
Unfortunately, we don't have a good treatment for them. People who have, recurrent meningitis with an autoimmune condition, steroids, and you could even use bigger gun immunosuppressants if need be. Methotrexate, for example, or rituximab. But generally, when the cause is not known, we really don't have a treatment for recurrent aseptic meningitis. And part of it is the cause may lie in the immune system. Something with an overactive immune system is we haven't really targeted that yet. So supportive therapies, Tylenol, the antiemetics, rest.
Yeah, your kind of safe headache treatment. So, making sure that people are fluid resuscitated, they're sleeping well, good dietary habits, not stressed.
Mm-hmm.
Before we wrap up the show, when you were researching this topic for that review article you wrote, what were some of the interesting concepts you learned in the process?
There's actually some pearls I have from doing this article that I can share that might help someone of my level of training. I think
everyone's level of training, John.
Yeah. I think for starters, patients that have genital herpes, that even though they may have more of a predisposition to recurrent meningitis, that disorder is still very rare. So even though the relative risk is higher, the absolute risk is still pretty low. And then what causes recurrent meningitis? There are still some theories that it could be someone's own problem with someone's own immune system. When actually there was a small study that they found that those who suffered from recurrent meningitis had more robust immune responses. They had their innate, and that their adaptive immunity was more robust. So that maybe there's something
suggestive of like an inflammatory response being the mechanism.
As opposed to the actual infection itself. And then looking at neoplastic meningitis, I think this is something that always crosses my head every consult I see. As someone who has a history of cancer, do they need a lumbar puncture? And generally for solid cancers, leptomeningeal spread is a late manifestation of the disease.
Very cool, Jon. What do you say we wrap up the show here?
So there are 5 causes of recurrent meningitis: infections, neoplasias, benign tumors, medications, and autoimmune disease. The treatment is going to depend on the underlying etiology. So for infections, if someone has viral infection, aseptic meningitis, there is no good treatment to prevent recurrent meningitis, but we did talk about the pluses and minuses of valacyclovir. For bacterial meningitis, you want to correct the underlying anatomic deficit, or if they have an immune deficiency, you want to either correct that and or make sure they're up to date on their vaccines. For neoplasias, you're going to treat the underlying cancer. For benign tumors, you're going to resect, the craniopharyngioma, you're going to take it out. And then medications, you're going to withdraw the offending medication, and you should see a reduction in symptoms within 48 hours. Then for autoimmune diseases such as lupus, Sjogren's syndrome, sarcoidosis, you're generally going to start with steroids. And if steroids don't work, you use higher gun immunosuppressants. And then for sarcoid, TNF-alpha inhibitors. Some of those can actually cause recurrent meningitis in themselves, which muddies the water. For a large number of patients, we never find the underlying cause. But I think the big thing, again, for people, at my level of education to take away is recurrent meningitis or, drug-induced meningitis. It's almost a diagnosis of exclusion. When someone comes in and they do appear sick to you, you should still treat them like they have a serious problem. You should rule out bacterial meningitis, and you should treat them for any known viruses. And then after the dust settles, you can tailor your therapy.
All right, so we're back in 2020. And since 2017, there are a few other updates and new concepts in the workup of these patients who have recurrent meningitis. So I asked Dr. Rosenberg to join me again back on the show and fill us in on the details. So, Jon, since we last spoke, you're now a fellow. Tell me about that.
Sure. So I'm currently a fellow in neurocritical care in New York City.
At New York Presbyterian Hospital.
So it's been good. Definitely a learning curve, learning adjustment. It reminds me of when I first started neurology residency, having to manage patients in the ICU, sick septic patients, having to manage my own airways. It's been a whole different kind of process, but it's been good so far. Challenging, but rewarding.
And in your practice of neurocritical care, I know you have been seeing patients with chronic meningitis or meningeal inflammation or encephalitis, NOS. What have we learned since you and I first spoke back in 2017 about chronic or recurrent meningitis?
Sure. So there's various infectious, non-infectious causes of this entity. Generally, with regards to infections, viruses are the big one. And although HSV2 is the kind of flagship virus for recurrent meningitis, Mollaret meningitis, often we don't find the etiology, and often there's various kind of viruses that we think there may be a recurrent infection, but we never really get the etiology if we can't actually get an assay for it.
As it turns out, perhaps a third of all cases of meningitis, or meningoencephalitis, have no identifiable cause, no infection that can be recognized from commercially available testing of antibodies, culture, or PCR assays, no obvious antecedent pharmacologic trigger, no autoimmune disease. A third of cases go undiagnosed.
So in the field of recurrent meningitis, we now have the advent of deep sequencing, metagenomic sequencing, which is basically where we use high throughput next generation sequencing to compare our sample, our CSF, and then we compare that to DNA of all kind of known pathogens. So
unbiased metagenomic next-generation sequencing. Like Dr. Rosenberg had mentioned, the genetic material isolated from a given patient's cerebrospinal fluid can be sequenced and essentially cross-referenced against a broad library of viral, bacterial, and fungal genes, as well as human genes.
They would test that CSF against all pathogens that they have common sequences for, and you'd find if there are any hits.
And UCSF, for the most part, is the principal site that's running this show. I mean, do you send your samples to UCSF? How does this kind of work?
So we send our samples to UCSF. At Presbyterian, we're actually starting to do our own metagenomics as well. But generally, when we have a case like this, we have sent stuff to UCSF.
Let me jump back in and talk about the data coming out of UCSF. 2 papers came out in 2018 and 2019, reporting the findings of more than 200 adult and pediatric patients with meningitis or encephalitis. In the 2019 New England Journal paper, the authors reported that of the 204 patients with available CSF data, half of them ultimately had no cause of their CNS inflammatory disease. 28% had an infectious pathogen identified on routine testing or next-gen sequencing. 8% had an autoimmune cause, cancer, 3%, and vascular or toxic or post-infectious and other causes. These accounted for the remainder of the patients. While an infectious pathogen was identified in a quarter of patients, 57 of the included population, it seemed that next-gen sequencing complemented conventional methods of testing. 33% of pathogens were identified using both modalities, while 45% of pathogens were identified only through conventional testing, and 22% were identified only through next-gen sequencing. So it's not exactly as if next-gen sequencing is on the way to replace routine cultures, ELISAs, and PCR assays. Not yet, anyway. And we don't really know all the limitations of this testing that well. Dr. Rosenberg and I talked a bit about false positives.
I think so. I actually do have a case back in residency of someone who had Powassan virus, actually, but we had a false positive from metagenomic sequencing as HSV. And I think at the end of the day, it becomes you have a hit. Does that result fit with the clinical suspicion? And then in this case, we continued treatment for HSV. When this result came back, it didn't really harm the patient, but we didn't really necessarily get to the right answer. So I think false positives can happen, but you, as a clinician with all tests, it's your job to kind of put it in the clinical context.
Some other findings reported out of UCSF worth mentioning are the sensitivity of the next-gen sequencing, which can be reduced when there's a large amount of host DNA in the sample, which you'd expect when there are hundreds and hundreds of white blood cells. Then there's also the concern, as with any novel assay or test that's not available on site, what's the turnaround time? Can the provider be given results in time to respond to this information and to adjust their treatment accordingly? UCSF reported a mean processing time of 90 hours per sample, from initiation of processing to pathogen identification and output. Thereafter, the data has to be interpreted by experts and pathologists. And lastly, what's the point of looking for some infections like Powassan virus, which have no known cure?
A lot of the viruses we can't treat, but I think there is power in knowing. One, from a academic standpoint, understanding how diseases evolve and natural history of diseases, and then being able to have this case as a reference case for you to help treat other patients. 2, it also helps pause the workup because, again, the differential diagnosis for recurrent meningitis is pretty broad, and it could stop your search for other things such as autoimmune diseases. Maybe there's certain medications that the patient should be on, like anticonvulsants, like lamotrigine, carbamazepine, and you may not stop those medications. You may continue them if you found another etiology. So if the testing is feasible, I still think there is utility to getting a diagnosis, even if it's a not a treatable condition.
And while there are a number of limitations and shortcomings to next-gen sequencing, I should remind you that this type of testing is unbiased and algorithmic. Often, the identified pathogens weren't even considered by the treating physician, and the testing evaluates the genetic material across a broad swath of pathogens, not just singular assays for the cryptococcal antigen or HIV RNA. So there's a lot of potential for these and for other novel approaches to identify infectious pathogens. Unfortunately, while we have made some progress in the diagnosis of occult CNS infections, we really haven't made that much headway in identifying the non-infectious causes of meningitis or encephalitis, especially for those 30 to 50% of patients who remain cryptogenic. So we still have a long way to go. That's it for another week on the BrainWaves podcast. Thanks again to Dr. Jon Rosenberg, who is now a neurocritical care fellow at New York Presbyterian-Columbia and author of the 2017 review article, Recurrent Meningitis, which you can find in Current Pain and Headache Reports. Music for this week's program was courtesy of Cold Noise, 3 Chain Links, and Uncanny. Sound effects by Mike Koenig and Daniel Simeone under a Creative Commons license. I'm Jim Siegler. See you next time.